closure of Hammersmith A&E that the Imperial Trust is now recruiting additional emergency medicine consultants. But I mean, why couldn't they try to recruit them to actually staff the Hammersmith unit in the first place? And the second question is, you mentioned £1 billion of capital investment, which obviously sounds very enticing, but is that contingent on making the £1 billion of savings first in order to raise that money, or where else is that money going to come from?
With regard to the question of staffing for Hammersmith, it wasn't a question of funding. I think I always want to cover this. It's the fact that because Hammersmith specialised towards cardiology and renal medicine, it no longer had the caseload to enable emergency medicine consultants and emergency medicine junior doctors and the rotations needed for those people to train in that facility to enable it to continue to staff with emergency consultants. It's not just a matter of funding the consultant post. There has to be the cases there for the consultants to continue their learning, to continue their improving their knowledge, their uptake of keeping with their skills and their improvement. I think that's why the centralisation of certain hyper-acute services have been proven to be so successful at reducing mortality and improving outcomes, because it creates a concentration of cases where instead of 2 or 3 emergency clinicians or 2 or 3 stroke physicians or radiologists who specialise in removing blood clots or whatever it may be, it creates that concentration where clinical excellence is allowed to flourish by 4, 5, 6, 7, 8 consultants in one specialty working with each other, talking to each other about new techniques and new practices, and that's why it's the kind of the accepted practice in the kind of the academic theory of providing acute healthcare. And very much if you refer to the work at the Academy of Medical Royal Colleges and the Royal College of Physicians, and I hope they're giving evidence to this commission, that's the kind of thing that they're talking about to improve patient care. And the other part of your question was...
The £1 billion capital investment.
The £1 billion capital investment.
Where would it come from?
Well, it comes from the Treasury, I assume, who will have to underwrite that investment. Obviously, no, hold on, I haven't finished. Obviously was what's about to follow. Obviously there will have to be some form of land sale at sites across North West London to partially fund some of that capital investment. I think in many ways, although people don't like the idea of that, from a healthcare perspective, where you can provide better healthcare facilities at the same time, better make use of your site, then it's incredibly sensible for organisations like that to do so, as long as it's done in a responsible manner. So obviously, to fully kind of summarise the answer, it's going to be a combination of write-off from the Treasury and funding from central government, combined with some later money coming in from other sources.
I suppose what I was getting at was yesterday it was a contract to build a new Papworth hospital was signed off at £140 million under the private finance initiative. Would you anticipate the PFI being used here?
From what I've been told, this is not proposed to be done by PFI, and I would be very, very, very sceptical and wary of PFI being used because of the problems that we associate with PFI from the last government. I think just to finish that point, I don't think necessarily PFI in itself is a bad idea, but I think where the scrutinisation and the contracting of PFI is not done rigorously enough. And there are examples in North West London where PFI funded hospitals and managed hospitals are creating a significant problem. I think I would not want any redevelopment in this borough to be linked to a PFI.